Hello everyone, welcome to our webinar entitled Nutritional Status and Hormone Balance. Our guest speaker today is Dr. Marion Owen. My name is Michael Chapman, and I'm a medical education specialist at Genova's Asheville branch. I'm going to serve as moderator for today's webinar. We would like to welcome Dr. Marion Owen. Dr. Owen is a resident of Decatur, where she lives with her husband and 2 children. A graduate of Davidson College, she received her MD from the University of North Carolina at Chapel Hill School of Medicine in 1999. She continued her training at the Emory Family Medicine Residency Program, graduating in 2003. She is board certified in family medicine. Between graduating from Emory and opening Whole Family Medicine, she worked as a family medicine doctor in Alpharetta, Georgia. In addition to her training in traditional medical therapies, Dr. Owen has focused her education on nutritional and genetic causes of disease and holistic approaches to healthcare throughout the Institute for Functional Medicine. She emphasizes lifestyle and nutritional therapies and collaborates with both MD specialists and alternative providers to guide her patients to optimum health. Dr. Owen appreciates close relationships with her patients, educating and empowering them to participate actively in their medical treatment decisions. And now I'm going to turn the controls over to Dr. Owen. Thank you all for being here today.
Very happy to be with you today, and I appreciate all of y'all taking the time to join us. We're going to be talking today about nutritional status and hormone balance. My particular objectives is I wanted to cover ways that we can minimize the risk that is incurred when we're providing hormone replacement therapy to our male and female patients. To do that, it's really important that we understand the metabolic pathways of hormone clearance, that we understand how nutrients impact those pathways and how we can support best status for those nutrients, and understand ways of addressing continued symptoms that patients might be having despite having good hormone levels, and how we might be able to address those without increasing hormone levels more effectively and more safely. We need to also, since we're talking about adding hormone to a patient, we need to recognize that any time we're modifying hormonal balance, we are potentially increasing risk. And so we want to also be focusing in those patients on how to optimize the health of all of their cells, especially breast tissue in women on HRT and prostate tissue in men who are taking hormone replacement. So how can we think about their cellular metabolism, their cellular health, so we're minimizing those risks at the same time we're providing them the hormone support that they seem to need. So before I will start hormone replacement therapy in any patient, I want to make sure that I've addressed anything in their lifestyle that might be contributing to their need or their feeling of a need for hormone replacement therapy. I don't think that everyone requires it, and so I think that there's lifestyle things we need to address first. And essentially, we need to optimize their diet. We need to look at how are they nourishing themselves, how is their stress level around how they're eating, is their gut working, just optimize all of that nutritional input. We need to assess a sedentary lifestyle. We know that people that are sitting most of the day are going to have more profound symptoms of low hormone levels than people who are physically active. I always like to at least assess and address any adrenal imbalances that we may see, because hormone replacement therapy, while it will help, if the issue is really an adrenal issue, it's not going to get at the core problem for the patient. I look at blood sugar, insulin-resistant parameters, thyroid imbalances. I like to assess pathways for methylation and sulfation before I get started on HRT to make sure that all detoxification pathways are going very well. And I like to do what I call opening the exits for detoxification. Anytime I'm adding a chemical in, I want to make sure that their body is good at getting it out, so that they're having regular bowel movements, they're drinking enough water, they're exercising, or at least sitting in a sauna to get some sweat going, get those lymphatic tissues opened and releasing. I think that that's really critical before you start adding any therapy, any prescription medication, certainly. So how do we know that we have someone's diet optimized? Well, if you're really not sure, you really think the patient is like ground substance not ready for hormonal intervention, I think it's very helpful to get a NutrEval test. That's offered by Genova. It's a very thorough kind of I like to tell people it's a comprehensive look at your biochemistry today. How are things going? Are you clearing them out? Are they building up? Do you have clear deficiencies? Are you getting enough fatty acids? Do you have toxicities that might be contributing to the way you're feeling? It's a really nice snapshot for the patient. The NutrEval, the first page, I'm sure many of you have seen these, comes with kind of a abbreviated version of all the data that's then in the millions of pages that follow, but gives you a good snapshot of this. These are the things the patient seems to have increased need for. And if you see a patient like this, it may very well be that if you correct that folic acid deficiency and the B12 and B vitamins in general, support that antioxidant and minerals, that their symptoms of estrogen deficiency resolve without needing to add any estrogen at all. You will get a recommendation for particular dosing, and I usually find this to be a very, very safe place to start. Sometimes patients do require more than this or more targeted types of folic acid or B12 or B6, but this is always a very safe and good place to start. You will get amino acid recommendations. Does the patient seem to have a deficiency? Is there a pattern that might suggest maldigestion, absorption of proteins? Certainly mitochondrial activity and muscle building and fatigue, brain neurotransmitter function, all of these things would be impacted by a protein deficiency state. So it's nice to be able to see that. So when do I start hormone replacement therapy in my practice? After I've cleared up those underlying issues we talked about before, and I have a woman in front of me with severe hot flashes, severe sleep disturbances, a new emotional disturbance that is unusual for her. So if this is a depressive person and they're depressed again and it's the same pattern, I might not say, oh, HRT is the answer. But if it's a new or a change in the way it manifests, very often it is. People that are experiencing increased joint pain, muscle stiffness, and they're not able to exercise as much as they would like because of the loss of lubrication with low estrogen levels. That's another indication from my point of view. And then, very concerningly, there's increasing data that there is a rapid decline in women in cognition, processing speed, and memory with menopause, and that subset of women that has that happen is at increased risk of Alzheimer's, and there does seem to be some early data supporting use of HRT in them to prevent that. So that's something I'm also really trying to key in on now. In men, if I have a male patient that has what I call a lack of wanna, they just kind of don't want to do anything, they don't want to go to work, they don't want to go out with friends, they don't want to have sex, they don't want to engage in anything, that's a good cue for maybe their testosterone is low. So when I have a male patient with low testosterone that's moving metabolically in the wrong direction and their estrogen levels are normal, I will replace testosterone. So after I have someone on what seems to be a good symptomatic control level of hormone, and I'm not going to go into the details of dosing and everything, that would be a much larger lecture. What do I do to monitor them? Well, initially they come back, they've had a month where they feel like, yes, the levels are good, not having any problems, we've corrected what the underlying issues are. I will check just in regular serum. I'll do, through Quest or LabCorp or Basic Lab, a blood count, liver and kidney functions, hormone levels. Usually I'll add some thyroid just in case those levels have gotten bumped by addressing the other hormones. Sex hormone binding globulin is important to assess. And then we assess the patient, of course, checking in with symptoms and are they having weight changes, because that's often a clue that you're doing something wrong if they're starting to gain weight. So once I have these initial labs back and everything's looking good, quick word about sex hormone binding globulin. This is an issue especially in male patients. Often we give testosterone, but their SHBG goes up and they're not really getting the benefit with that free testosterone going up. And you need to kind of consider what else might be going on with that. You need to look at underlying lifestyle things. Alcohol use and liver damage is commonly present. High cortisol is something to consider. Insulin dynamics, actually high insulin can lower sex hormone binding globulin, and that can create disturbances in how they're responding to hormone therapy, if that's an issue. And often when sex hormone binding globulin's high, I consider whether or not maybe my dose is just too high. I'm giving them too much, so they're having to regulate their binding globulin, and I'd rather not have the overall dose in their body be any higher than it needs to be. So often that's a clue to me to adjust the dosing down. But if you have a male patient and you get their testosterone level low and their estrogen's good, and you add testosterone and now they're starting to make a lot of estrogen and having some central weight gain, you really need to think about the aromatase enzyme. This is an enzyme that's in our fat, and it converts testosterone into estrogen. And it's really hard to lose weight when your estrogen is high. Ask any woman who's ever tried. It's very, very difficult to lose weight with high estrogen. So we need to address that. And you need to address the underlying causes of the weight gain. Maybe it's that they do have some dysglycemia, and you need to maybe do metformin, and some people are doing very well in my practice on berberine. Or you need to consider adding an aromatase blocker. And I have a list here, and there's tons of information online about natural aromatase blockers. I'm going to just say clinically, I do not have great results with that. Maybe I don't dose them high enough, I don't know. But what I tend to do, since I can prescribe things, is I prescribe very low dose anastrozole, which is an aromatase inhibitor approved for breast cancer treatment. So I will use that in an off-label way and discuss that with the patient, of course. But I find that to be extremely helpful. So then once I've kind of got my basic labs corrected, the patient feels like they're going in the right direction, what do I do to make sure that I'm not increasing harm? After all, my job is to first do no harm. So I will always check urine metabolites of estrogen in everyone that I'm putting hormones into, because any of the hormones we use can be converted into estrogen. So we need to see how are they clearing that out. If a patient is still not sleeping, or they're just really emotionally friable and their levels look really good, but just something's still off, I think it's really important to back up and look at their adrenals and see if there's something going on there. Do they just not have any cortisol helping them kind of deal with the stress of the day? Then I can also will often get organic acids that's part of the NutrEval test, and it helps to assess for any deficiencies and depletions that may be happening because of the estrogen therapy. Estrogen, to be detoxified, can deplete folic acid, B12, B6. It can create some mineral fluxes. So it's good to get a good look at their post-hormone replacement therapy nutritional status and not just pre. And so those are tests that I'll do kind of stepwise. I'll do metabolites, maybe I'll get adrenal. Once we address the metabolites, we'll look again at those organic acids and just make sure everything's flowing the way it's supposed to. So this is a report of estrogen urinary metabolites, and I find this to be very helpful. It looks at the pathways that these hormones are escaping our body from. The first thing that happens is, estradiol and estrone can both be converted. They can be hydroxylated, and then they have to be methylated. And so this is looking at estrone as our representative hormone. How is it being metabolized and cleared out of the body? So once an estrogen has been, estrogen, as you remember, probably looks kind of like chicken wire. It's got 4 different kind of circular carbon globs, and each one of those carbons gets a number. And your liver can put an OH group on the 2nd carbon, the 4th carbon, or the 16th carbon, and that's step 1 for getting rid of them. And you see labeled there on this image which CYP enzyme does that work. And so once they're hydroxylated, they need to be quickly methylated, because it is the hydroxy-estrogens that can be a little bit more toxic. And so when you look at this, you can kind of see the ratios. You can get a glance of, are they methylating the things they're making? Are they hydroxylating well? Are their hydroxylation pathways balanced? It's a nice, quick and easy interpretation, and extremely helpful in figuring out what might be going wrong. Also, in follow-up testing, again, I will get urinary organic acids to look for those B vitamin deficiencies, and red blood cell minerals, which are also available through Genova, to look at the mineral imbalances. So if you get the test and you find a deficiency that's being created post-replacement, of course you're going to address that, follow the patient symptomatically, and then of course I would recommend you follow up with a repeat test to make sure that you've done what you need to do to correct the problem. And again, you'll get dosing advice with that. Quick word about the 2 to 16 hydroxy-estrogen ratio. This is, and currently under debate how useful it is. Very early, when we were first starting to be able to investigate the pathways for estrogen metabolism, it seemed clear that breast cancer patients had a higher 2 to 16 ratio than non-breast cancer patients. Further studies seems to be calling that into question in postmenopausal women. It's still maybe the case in premenopausal women that ratio is important. It's still certainly something I look at. I kind of like to look at the balance of the 2, 4, 16 in general, kind of thinking, well, everything should just be flowing and open. That's my general rule. If the body can do it 3 ways, let's let it. But the relationships between the 2s, 4s, and 16s, and of course the methylation part of that, I think, is the most important thing to focus on at this point. But all those ratios and the whole balance of them needs to be taken into consideration. So the 2 hydroxyestrogens do seem to be maybe a little bit less aggressive at the breast, maybe some slightly less estrogenic activity. That was the early reports. It has been associated with low bone density if 2 hydroxyestrogens are too high. So again, I just think it's important to focus on the balance here. The 16 hydroxys have been associated with a slightly higher bone mineral density. So again, you just want to look and make sure that everything seems to be in a nice place. And again, because you can see those pathways, which hormone is leading in that direction, which enzyme is moving to the 2s, the 4s, and the 16s, you can do some dietary and lifestyle modification to improve those. The 4 pathway, I think there's no question that the 4 hydroxyestrogens, especially if they're coming from Premarin detoxification, are extremely damaging. They're directly genotoxic. The metabolites actually can insert themselves and create breaks in the DNA. So 4 hydroxyestrogens being high make me very, very nervous. So I like to see that 4 methyls are happening if the 4 hydroxys are there. And I think that's a very important thing to look at, because once they're methylated, they don't damage the DNA in that way. So again, the hydroxyestrogens can create direct damage, and so we want to look at that ratio. So when you look at this result, you see those 2 hydroxyestrogens aren't very high. They're in that nice low green zone. And if you drop down a few lines, on line 4, the 2 methyl estrogens, those look pretty good. They're both kind of low, but both low. Whereas if we look at the 4 hydroxyestrogens, that 4th line, that's a little high. Okay, well, are we metabolizing that? Well, look at that 4-methoxyestrogen. It's non-detectable. So they're making hydroxys that they're then not methylating. And I've got to say, I see this pattern a ton, where the patient seems to be able to methylate their 2 hydroxys, but they're not good at methylating their 4 hydroxys. And to me, that's a flag to say, hey, go ahead and upregulate that 2 hydroxylation pathway a little bit. Let's try to downregulate the 4s because you don't handle it well. And wow, you need some methyl support because we've got to get those hydroxys cleared out. So this is a pattern that I see a lot, this exact 2-4 ratios. So how do you clear them out? Well, the first thing is don't make them in the first place, so keep your estrogen dosing as low as you can to manage the symptoms that are creating the lifestyle problems. And I don't think that you have to erase the symptoms completely. Just get them to the point where the patient is comfortable. Yeah, I can handle 1 hot flash during the day, and I can wake up with a hot flush at night and cool off and get back to sleep. I'm okay here. You don't have to ramp up the estrogen just because they're still having mild discomforts. To clear hydroxys, you need to do methylation support, and you need to give them active forms of B-complex. If you're having trouble and you just can't get through it, or you can't figure out how to get them to tolerate B-complex, it is extremely helpful to look at the enzyme COMT that does that. There are a lot of known SNPs, single nucleotide polymorphisms of that enzyme gene that can create a less efficient form of COMT, and so you'll have a patient that just really has trouble doing that activity. You can also look at the MTHFR genetics to see if they have trouble activating their folic acid, utilizing their methyl groups, and getting them to the COMT enzyme to be useful. So both of those can be done and can be extremely helpful in a patient you're just stuck with. So again, because the 4-hydroxy-estrogen seems to be more damaging than the 2, I really encourage patients to eat cruciferous vegetables because they upregulate 2-hydroxylation, that CYP1A1 enzyme. I will also, in patients that just don't eat crucifers, go ahead and support with I3C or diindolylmethane. I'm rather neutral on which one of those I use, and it varies. And then you want to prevent reabsorption. As you recall, when you detoxify these hormones, all this is done in the liver. Well, when you detoxify things in the liver, where does it go? Well, it goes into the bile, and then it collects in the gallbladder. So then when you eat, your gallbladder squeezes, and all that glop, all those toxins just go into the gut. Well, if you have a leaky gut or bacteria in the gut that like to unconjugate things, then you're just going to reabsorb these detoxified estrogens. And then they're detoxified, methylated, bacteria acted on things that I'm certain we can't measure, but they're not good. And so we want to have people bind them up and get them out. So a high-fiber diet, especially flax lignans. And clinically, I'm finding that people who have flax first thing in the morning seem to get the most benefit from it. And I just have this like image in my head that during the day, our liver's busy detoxifying all the stuff we eat. So at night, it must be packaging up all the estrogens and putting them into the gallbladder. And I'm not sure that's accurate. That's just the world according to Marion. But I do find that the morning, that first time you eat, get some flax in there, and these estrogen toxicity symptoms seem to really drop. And I usually recommend 2 tablespoons of ground flax. I have a few patients that just can't manage that. It's just the taste or the texture or something, and you can get flax lignans in a capsule form from many distributors. And you want to support sulfation through use of N-acetylcysteine, methylation support. Of course, methylation and sulfation cycle back and forth with one another. Supplementing glutathione if you suspect your patient is poor at making glutathione. And if you're really stuck, getting a NutrEval can sometimes uncover biochemical blockages that you can't necessarily guess, but once you address them, wow, look, your estrogen symptoms got better. So again, really keep that one in your pocket and use it a lot. It's a very helpful test. So a word about MTHFR genetics. So this is the enzyme that takes folic acid from the form that it comes in food and makes it into the form you can use it in your body. So it has to be 5-methyl tetrahydrofolate really to be an effective methyl donor. And so if you don't have the enzyme that does the work of moving folate to 5-methyl tetrahydrofolate, you can give that patient all the folic acid you want, and they're not going to be able to methylate. So you've got to, if you know about the MTHFR genetics, then you can appropriately dose 5-methyl tetrahydrofolate to support that. And so the 2 main kind of known quantity MTHFR SNPs are the C677T, which is the one that most profoundly affects the methylation that we're talking about, and then the A1298C. That one also affects the ability to make 5-methyl tetrahydrofolate, but it also seems to it doesn't necessarily raise homocysteine in the same way, so you might not see that in a lab when it's just the 1298C. And I also think those patients, and I'm not sure why, tend to do better with a little extra folinic acid as well, just a different form. I still give them the 5-MTHF as well. If you suspect that the patient has a COMT problem, and the way to suspect this is either because you've looked at their estrogen metabolism or they're just really, really anxious people, then you really need to drip methyl support in slowly. Anxious people, because if they're anxious because of a COMT problem, if you give them too much methyl, you can really kind of send them into a panic attack. So you need to do that slowly. So COMT genetics, this is the enzyme that detoxifies estrogen, but it also is the enzyme that puts methyl groups onto dopamine, epinephrine, and norepinephrine to get rid of them. So if you're a slow COMT person, and you get a little bit of adrenaline at the beginning of your day, you're going to be anxious all day because you can't get rid of it. And so these patients are typically pretty easy to ID, but sometimes it's really helpful to get this COMT enzyme to help them see what's going on, because sometimes their anxiety can be extremely difficult to manage. And again, you have to be really careful as you put methyl support in. I will generally try just a low-dose balanced B-complex first. If they can't handle that, I'll back down just to methyl B12. And I may even back down to a non-methylated form of B12, like hydroxy or adenosine B12, if they're even sensitive to the methyl B12. The B12, because it grabs the methyl group from the methyl tetrahydrofolate, it allows those methyls to be passed on. So if their B12 is inadequate and you just add the folate, you can end up with too much methyl that they can't deal with, and somehow, and I'm not sure again how, that seems to overwhelm this weak COMT enzyme. I have seen in a lot of literature that people with COMT do better with SAMe. I have not had luck with that clinically. I find that SAMe makes them anxious and insomnia, but it's worth a try. Start with a really low dose and always go slowly when you see a COMT patient. So if they're still having symptoms, you've got their levels good, you've got their detox locked in, you've got their NutrEval going well, what are we doing wrong? Well, you need to back up and think about what else might be creating their problems. Could it be heavy metals? Women who have gone through menopause tend to have their bones thinning. Metals that have been deposited in those bones will start showing up, and heavy metals will, to quote my teenage daughter, jank up the mitochondria. They just get in there and keep it from being able to do its biochemical processes. It creates oxidative stress. And so even though you've got the machine lubricated with good hormones and everything's in balance, if the mitochondria can't respond appropriately to the signals that those hormones are signaling, it's not going to work anyway. So you've got to back into the mitochondria, look at the metals, look at their adrenals. Do they have a sleep disorder? A lot of times there's a little bit of weight gain around menopause and andropause. They've gone from being heavy snorers to being sleep apneics, and that's a really important thing to rule out when someone's having, especially if their symptoms are mostly just nighttime. You want to look at that. You want to look at, could there be a dysbiosis causing estrogen metabolites? When I first started doing functional medicine, I always started with the gut. And then I went through a period where I thought I could tell when someone's gut wasn't a problem and we could go on and move to something else. And about 3 out of 4 times, eventually we get to the point where I'm smacking myself in the head saying, I really should have started with your gut. So if you think a patient might have a dysbiosis, they do, you should assess it. And the GI-FX is an incredibly helpful way to do that. Do they have a dysglycemia or high insulin that might be interfering with the normal hormone signaling? Insulin dominates everything. So if it's there, it can just be creating symptoms. Even though the estrogen's there, it can't do its job because the cells are busy dealing with the insulin and the high blood sugar. Again, nutritional deficiencies that might be affecting the cell's ability to respond to the hormones. And then often at this point, I'll also check, I usually have done it initially, but I'll check again, DHEA and pregnenolone, the precursor hormones. And sometimes a little bit of pregnenolone can just be very helpful in a postmenopausal woman. When their levels are low, you add just 5-10 milligrams, and it can make a huge difference. I'm still a bit baffled by that, but it is true. So okay, we've got their hormones balanced, they're feeling pretty good. How do we also prevent them from having any added damage? Because you are adding a toxin with hormones, so how do we help them pull that out. You want to make sure you've got their oxidative stress as low as you can. You want to maximize their mitochondrial health, have them avoiding known triggers that might be generative of cancer, the plasticizers, parabens, things like that. Immune system support, so the immune system can notice when the cells are starting to go awry, clear them up and get rid of them. And blood sugar can be very helpful. High blood sugar feeds cancer, so keeping the blood sugar low is very important. So our best antioxidant is exercise. The importance of regular physical activity, deep breathing, and delivery of oxygen is just, there's just so many studies on that, reducing cancer, reducing recurrence of breast cancer, preventing initial incidences of cancer. It's just everywhere. In addition to an issue that near and dear to my heart, which is decreasing dementia risk. Antioxidant supports, you should, there is no good study that says, wow, just supporting antioxidants in general prevents cancer, prevents heart disease, prevents anything. We can all nitpick about how those studies are done, but so does that mean that targeted, selected, well-targeted nutritional therapy in someone who, say, has high lipid peroxides isn't helping them? No, I think that there hasn't been no study that says that is true. So if you have a patient and you know they have high oxidative stress, doing antioxidant support, I think, has high reasoning behind it to say that you are preventing something, even though the studies aren't necessarily there to back you up at this point. So the NutrEval, or the more targeted oxidative stress analysis, can be really helpful here in patients who want to optimize. With the NutrEval, you get glutathione levels, lipid peroxides, 8-OHDG, which is oxidized, the G of DNA, guanine, so it's broken DNA that has been oxidized. That doesn't sound good to me. And then CoQ10. So you get measures of 2 representative antioxidants and 2 markers of just, wow, there's some oxidative stress here. And when you see that, you really want to look at what's causing, especially like an 8-OHDG of 113. That's pretty concerning for precancer or cancer, and certainly cancer risk. So how does oxidative stress intimately affect estrogen metabolism, our main topic? Well, oxidative stress depletes methyl donors because when you have high oxidative stress, you're going to need more glutathione. Well, glutathione is made via pulling homocysteine out of this methylation cycle down by cystathione beta transferase. It pulls it out, and an outcome of that is glutathione. So if you're working hard to make glutathione, you're going to be depleting your methylation cycles. So when someone has high oxidative stress, you also need to think about supporting their methylation, so you're supporting their process of glutathione production. So mitochondrial health, every cell in your body has thousands of mitochondria in it. So if you think about all the ways mitochondrial health might impact overall health, it's everything. It's overwhelming. But specifically for cancer reduction, if your immune system is energetically challenged, you're not going to fight off early cell changes. You're not going to clear them out very well. You're not going to clear viruses. You're not going to clear other things either. But you also will be generating more oxidative stress. So when do you think about a mitochondrial issue in a patient? Patients whose thyroid levels are normal, but kind of then telling you that their thyroid something's wrong with their thyroid. And that's when I think mitochondria. They don't recover after exercise. They can exercise okay, but they can't recover. They have brain fog, especially after exercise, weakened immune systems. They don't wake up feeling good. They don't have that recovery system because their mitochondria are always a little bit behind, always burdened by oxidative stress. And the best way to assess this and come up with targeted therapies for it is through that organic acids profile and lipid peroxides. So in the organic acids, you get all the intermediates that are happening in the citric acid cycle, which, as you recall, is happening inside the mitochondria. And this is where we're generating the biochemical energy that then later will capture in the electron transport chain to generate that ATP that gives us our cellular energy. So if there are places where that process, that biochemical process, isn't running smoothly, you want to figure out what's causing that and open up those pathways. So on this report, you see that, a patient's alpha-glutaric acid is high, their succinic acid is high, and then you can look back at the pathways and say, oh, well, aluminum might be doing that, or wow, they probably need a little bit more B2, but you can start to see patterns that can help you address those biochemical level mitochondrial disorders. And then with the lipid peroxides and oxidative stress markers, you kind of know whether or not you need to be targeting that more heavily also to protect the mitochondria. When you think about cancer prevention, I hope that you immediately think about the toxic world that we live in. I unfortunately have to live in the Atlanta area, and it's just very toxic. But there are a lot of environmental triggers out there for mutagenesis, and some of them we're doing to ourselves intentionally and don't have to be. The phthalates, parabens, plasticizers, animal fat seems to be a repository for these things, and I think that's why it's kind of a pro-cancer thing. Alcohol, antifungals that we put into the plastics that surround the food that we eat, antibacterial things that they put on children's hands before they eat at school that contain triclosan, which is a known anti-testosterone. These things are everywhere, and you cannot avoid exposure to them. And sometimes it really is the thing causing your patient's problem, and it's hard to know when to assess that. But when you have a patient that's just tired and isn't getting better or just wants to be optimally healthy, the Toxic Effects Core Profile can be really a nice place to start. Where are your toxic burdens? It assesses the phthalate levels, paraben levels, and then you also get some helpful ideas as to how to help people clear those out, which is good because I wasn't born knowing. You get a bisphenol A profile. So happily now things are labeled, does not contain BPA, BPA free, and I think that's great, but then I'm holding the plastic bottle thinking, but what did they use instead, and what does that do? I still don't really trust it. So, but again, when a patient sees this, wow, my BPA is high, okay, I will avoid eating things out of plastics. We can all do that. Phthalates, they have been shown to directly affect the estrogen receptor. There have been some studies that indicate decrease in male reproductive development, linked to endometriosis, certainly linked to obesity. All of these toxins are deposited in our fat, and our fat grows to try and decrease the toxic burden. So we get fatter when we get more toxic. The parabens, these are everywhere. They're in your shampoo, they're in your face cream, maybe not yours, hopefully you're an enlightened crowd, but your patients are using these things and say, well, they're dermatologically tested, they're okay, but no, these parabens, they're weakly estrogenic, yes, but if you're putting them on your hair every night, and your face every night and every morning, and then you're wiping your hands with them before you eat, our load of these things is very, very high. And the problem with this and all toxins is that they're synergistic. It's not just parabens, it's parabens and phthalates and triclosan and heavy metals, and it's the overall burden on your body. So any of that you can offload is helpful. But parabens specifically have been shown to perhaps have a role in male infertility. So these things are definitely estrogenic or hormonogenic, and maybe not in a great way. To also prevent cancer, we want to focus on immune support. How do we get the immune system to notice when things are going wrong and stop that early? That's what we want. Exercise and stress reduction are critical for a good functioning immune system. I am a big fan of mushrooms and the crazy cell walls that mushrooms have, those weird carbohydrate complexes. They do something really positive for the immune system, and I encourage my patients to try and get at least 2 servings of mushrooms a week. Gastrointestinal health, if you're 70% of your immune system is irritated by whatever's going through your gut, it's not going to be doing a good job of surveillance. So you want to keep that intestine healthy. Adequate vitamin D very clearly has an immune system support role. It's involved in that early, when the immune system is asking the question, is this me or is this not me? And as a cell is going from me to cancer, there's a moment when my immune system needs to say, oh wait, that's no longer me, and it needs to eat it and get rid of it, and I want to never know about it. So vitamin D is important in that self-recognition part. So keeping vitamin D levels, I think 55 to 75 is a good safe range, and that is where I aim for my patients. And again, antioxidant support. You want to make sure that your patients are eating an antioxidant-rich diet, that antioxidant-rich diet is achieving its end, that you don't have high oxidative stress, that they're exercising and balancing their stress so that they don't have an immune system that can't manage any risks that were to crop up for them. And briefly about blood sugar, it's just really clear that cancer cells use glucose for energy. So if you keep glucose low, they don't have any energy. They're not going to grow as fast. So helping your patients maintain a nice low blood sugar is really important. It's good for anti-cancer. It's also good for your brain. So as part of my yearly physical, and with most patients a little bit more often, I'm checking fasting insulin, their glucose, their hemoglobin A1C, or fructosamine, kind of depending on what I need to do to make sure that that blood sugar isn't going high. So very quickly, I'm going to run through a case for you. This is a 59-year-old woman. She'd actually been menopausal for 8 years and had been feeling fine, and she'd been my patient for about 5 years before this happened. And one of those examples of, oh, you can go through menopause and not have any problems. And she really was. She had never taken any hormone replacement therapy. She had what she considered to be a very low-stress, balanced job, good supportive partner. He had some health problems, but they were stable. So there's nothing really had changed from her presentation. And then, boom, kind of out of nowhere, she just started hot flushing. And she was hot flushing a lot. It just kind of like was suddenly, one time with every client. She worked with a psychotherapist, so that was very uncomfortable. Excuse me. And then she was waking up multiple times every night. So back up and start at the beginning. Are you exercising? Yes. She was a regular tennis player, and she walked on the days that she didn't play tennis at a good clip. She was physically fit. Her diet, she didn't eat a lot of vegetables, so immediately you start thinking oxidative stress. She ate organic simple carbs, but they were simple carbs. Lots of crackers, chips with organic hummus. So kind of the organic junk food diet. At her last physical prior to this, her homocysteine was found to be high. I believe it was 10. And her hemoglobin A1C was 5.7, which is right at that pre-diabetes cutoff. So we had at that time recommended that she adjust her diet. She had not yet done that, but she had started taking a B complex. So she was not interested in hormone replacement therapy. So for the next year, we kind of saw her every month or so. We worked on her adrenals. We tested them. They actually looked really balanced. Her blood sugar management got in line. Her A1C actually got down to 5.4. We ended up on both a B complex with some extra 5-methyltetrahydrofolate, and her homocysteine was under 8. And most of her daytime symptoms were resolved just by addressing those things. But her nighttime symptoms just continued. She was waking up just drenched. And the lack of sleep was increasingly causing anxiety. She was feeling depressed. Things were not okay. She continued to be resistant to HRT. I really wanted to try just a smidge of estrogen to see if it would help, but she was not interested in that and elected to use Ambien. And that was effective for a while. She was sleeping. A little follow-up later, her bone density was rapidly declining. And so with that kind of saying, wow, maybe estrogen is really too low, she was like, okay, we'll start a hormone replacement therapy. So before we did, her initial estrogen serum lab was undetectable. My lab doesn't go below 5, and hers was less than 5. I started her just in a few drops of the Hargrove formula. I don't know. I can supply that formula if anyone needs it. And her symptoms were immediately better. She was able to really reduce her Ambien. I think she went down from using 10 milligrams every night to using 5 milligrams if she woke up. and couldn't get back to sleep, and that was happening like 2 nights a week. Then I checked her serum levels. Her estradiol looked good. Progesterone was good. It's a little low, but not bad. Testosterone was good. And if you'll notice, all of these are menopausal levels. That's what I aim for, a normal, mid-normal menopause. I don't try to go super high because estrogen scares me a little bit. So I try to aim to keep patients in that menopausal window. And she was, and her symptoms were much better. So we decided to check estrogen metabolites to make sure that with this stable dose, she was doing okay. And so immediately on looking at this, you'll see that her hydroxy-estrogens, if you just kind of glance down, they're very high, and her methoxy-estrogens are not detectable. So her homocysteine was 8, which tells me, wow, I'm doing a good job at methylation. But if I hadn't checked this, I wouldn't have known about this very potentially dangerous estrogen ratios. So we've got really imbalanced hydroxy to methoxy. So we addressed methylation. We added B12, we added betaine. We encouraged estrogen clearance by adding that morning flaxseed. And I encouraged cruciferous vegetable intake, again, kind of the shift toward those 2s that I see getting methylated easier. That's just what I see clinically. And she, again, felt well. Her sleep was improved even more, was having reduced hot flashes. Then she had a wrist injury and ended up getting a few steroid injections. And her hot flashes went through the roof. And then she got really bad breast tenderness. So I was, based on some bloating symptoms, I was suspecting a dysbiosis and some shifts in her metabolism kind of forced by those steroid injections. And then, as it turns out, she also was exercising much less. That wasn't clear at the time, but she was a tennis player, and the wrist that she injured was her tennis hand. So she wasn't doing as much physical activity, so her oxidative stress was much higher as well. She had also, when you're not exercising, you're not feeling good, and you hurt, you change your diet. So she'd increased her sugar, she'd stopped using her flaxseed, she'd reduced her methylation support, and we were like, okay, you got to get all that back in check. And we addressed all that and said, okay, we still need to check your metabolites. We went, she was back to where she had been before with that previous test. And I said, now we need to check your metabolites and see are we doing adequately? Are we doing a good enough job? So this was the follow-up. And her 2 methoxy estrogen panel did look better. She still just does not methylate those 4 hydroxy estrogens. And I don't know why, but again, I see this a lot. And so that's why I kind of like to support that 2 pathway. It's like, well, if you can methylate it, let's move that way. So hang on. We added I3C because she wasn't eating her crucifers, and re-upped on her diet and making sure she's doing her flaxseed and exercise, and the breast tenderness completely resolved. Her sleep issues continued on and off during times of stress, but were overall much better. And then a few months later, she came in and said that she'd had a divorce. And in fact, when all of this started was when she was beginning to realize that she was going to need to have that divorce, but she was in pretty profound denial about that. And once all of that resolved, we were able to, through diet, exercise, and methylation support, she continues on low-dose estrogen but has no continuing low estrogen symptoms and no symptoms of estrogen toxicity. So I hope that was a helpful case for you, and I'd be happy to answer any questions.
Thank you, Dr. Owen. That was a great presentation, and we've received some great feedback. Just want to remind everyone that the PowerPoint will be available on our website in PDF format. We did receive quite a few clinical questions, so let's start with, there was a question with respect to using flax, and the question was, is it the fiber in the flax that you find to be effective, or the phytoestrogens?
So I am using the flax for the lignans that I understand bind estrogens from the bile. I certainly can't know whether the phytoestrogens that are in that flax are helpful, but that's not why I'm particularly using it.
Okay, great. Another question was, why do you choose to use the NutrEval over the organics?
Oh, you just get so much more information. I'm able to, because I'm an insurance accepting practice, I'm able to offer my patients the easy pay option with Genova. And so for like $20 more, I can just get tons more information. So I like getting the fatty acids and the heavy metals and the red blood cell minerals and all the other, and the oxidative stress markers. So it's just a much more comprehensive panel. And, also I think we get into habits. And when I started learning how to interpret these tests, I started using the NutrEval, very early on. And so, I can look at one of those really fast. So it's just what I'm comfortable with, what I know how to interpret most easily. I think that the organics and the ion from Metametrics, now Genova, are also really helpful. They just take longer for me to read because I'm not used to them.
All right, great. Another question about what ratio of, between the 2 and the 4 and the 6 hydroxy-estrogens do you like to see?
I like everything just nicely balanced in that green zone. I like it to be kind of mid-green. So I don't have a particular ratio. I just, as I'm glancing down that little grid that comes with the test, I like to see everything, right there in the mid-normal. I'm a big mid-normal fan.
Great.
Kind of on everything. Thyroid, hormones.
Another question with regard to using DHEA. Do you use that in men, and do you use it versus testosterone therapy?
I will use DHEA in men. I don't find it having as much clinical efficacy in men. You got to go to pretty high doses in men because it's just so much quieter than testosterone, and you get their testosterone normal, and they're, the little subtle difference that DHEA adds is not usually critical. But I will do it. I test it, and if it's low, I replace it. But I find that often patients stop using it because they don't find it worth it. In women, however, because their testosterone levels are so low, the androgenic effect of DHEA can be quite noticeable. And so I definitely use that. And I also use it in patients with a lot of inflammatory arthritis issues because it has some data there too. But in this context, more with women, just my male patients, the feedback from them is they don't notice it.
Excellent. Just a couple other questions. If somebody does have an MTHFR SNP, what do you normally do to support that? So
if it's the C677T, if they're heterozygous, so they have one good copy of it, I'll just do 1 milligram of methyl tetrahydrofolate, and with that one you can watch homocysteine. So I'll start with 1 and follow their homocysteine. I like homocysteine for reasons from Alzheimer's research to be under 7 or below. So I just keep adding 5 methyl tetrahydrofolate until I get it there. With the C1298T, with the 1298 one, C's and A's, I think, that one doesn't budge homocysteine, so it's harder to monitor. So I will do, again, 1 milligram of 5-methyl tetrahydrofolate, and then I'll do 800 micrograms a day of folinic acid, and then I try to look at, you can look at the estrogen panel to see if the methylation is going well. You try to look for other signs that maybe methylation is or isn't balanced appropriately. And then, if they're homozygous, then I do higher doses. So heteros, I'll start at 1. Homozygous, I'll start at 5 milligrams of the 5-methyl tetrahydrofolate.
Okay, great. And then one last question was actually with regard to the NutrEval. Does it include SNP testing?
Oh, yeah, it can now. They just released it. I'm very excited to be able to offer that to some folks. It's an add-on, and I'm sure that my wonderful rep told me exactly how much that add-on costs. But you can add on individual SNPs. You can do the ones that caught my attention, or the ApoE, the COMT, and the methyl tetrahydrofolate. Michael, what other ones are on that?
The other one is NF-kappa.
Yes, enough kappa. And that's very helpful, especially if you feel like you got inflamed patients.
I'm sorry, I misspoke. It's actually TNF alpha.
Okay, TNF alpha, same thing. So an inflammatory marker, cardiovascular import, that's nice as well.
Great.
So those are add-ons now to the NutrEval, which is great.
So in the interest of time, we're going to end our question and answer period there. For additional educational materials, we'd like to encourage you to visit our website, www.gdx.net. On this site, you'll find sample reports, kit instructions, and other information for all our profiles. I wanted to mention that we are making updates to our website, so it may look a little different from what you see here on the screen. I would also like to let you know that we're having an upcoming Learn GDX seminar series event in Atlanta, Georgia. This will be a one-day event focusing on the microbiome and gut health on Saturday, February 20th. Speakers include Dr. Filomena Trindade and Dr. Andrea Gurman. For more information, please visit our website. After taking advantage of the materials found on our website, feel free to contact client services with your questions. You'll see a number on the slide for US and UK customer service. Additionally, please call client services if you need assistance in setting up a MyGDX account. We also offer complimentary appointments with our medical education specialists to answer questions related to our testing, including choosing the right test and reviewing patient test results. Finally, we'd like to encourage you to look for upcoming webinars on www.gdx.net. Next month, we will have Dr. Jamie Wright, who will be presenting Sick and Tired and on Fire, Nutrition and Inflammation. Thanks again, Dr. Owen, for a great presentation.